Subscribe to our YouTube channel and press the bell icon to get the latest updates.
Hi and welcome to ThePrint. Of late, we have had a lot of tragic stories coming out about young actors who we lost to heart diseases, to heart attacks. Recently, it was Siddharth Shukla that shook the nation, and then more recently, we had, Puneet Rajkumar, who also passed away due to a heart attack. And these incidents sort of gave rise to a lot of primetime debates about heart attacks in general, whether Indians are getting, affected by heart diseases at a younger age, and whether we as Indians should worry more about, our changing lifestyles, and whether we are genetically predisposed to the disease. So to discuss all of this and to separate myths from the facts of heart disease, we have with us Dr. Karthikeyan from AIIMS New Delhi, who prefers to being called as Dr. Karthik. Hello and welcome, sir. Welcome to ThePrint, and thank you so much for taking out the time to speak with us.
Thank you. Thank you for having me.
So, to begin with, the basic question, the question that everybody has is, are Indians suddenly more prone to heart attacks or heart diseases? Is this a new trend? Are we suddenly more at risk from this disease?
Okay, so this is one of the key points that's been doing the rounds in social media, that we are somehow inherently predisposed, meaning that if you are Indian, you are at high risk of having a heart disease, heart attack or something like that. So it's useful to just step back a little bit and see how this whole thing came about. So in general, what has happened is, when you look at heart attacks taking place in a country, you try to look at what is the average age of the people who get heart attacks. So if you look at a country like, say, the United States or UK or Sweden, for example, you'll find that the average age is something like 60, 65. On the other hand, if you look at Indians having heart attacks, on the average, the age would be something like 50, 53, 55. So the conclusion that people have drawn from that is, on the average, Indians are younger when they have a heart attack. Now, and this has been somehow linked to an inherent predisposition, which I believe is not entirely correct, because if you see the Indian population structure, we have far more younger people than older people. Whereas if you look at, say, a developed country, they have far more older people. So the risk of a heart attack increases starting with age 35, and it goes on till age 80, 90. So these people have more people who have heart attacks at later ages, and they have a larger population of older people. So as a result, it's just a mathematical thing that you have an average age which is higher. Now, this in no way suggests that we are more predisposed. So the other thing that I want to point out here is that if you really want to look at whether a group of people is getting more heart attacks or not, then you just look at the numbers of heart attacks that people develop over a year and look at the denominator of the people. So one way of looking at it unbiasedly, in the sense that if you take away the age differences between countries, so if you want to compare Sweden with India, for example, you have to standardize the age. So you use a standard population and you look at the incidence. So if you look at it that way, the incidence of heart attacks between, say, India, and people have been talking about Western Europe as a comparator. So if you look at it, the numbers are quite similar. Numbers of heart attacks per year in an age standardized population are quite similar. But that doesn't mean that. So this is one thing. So we are not inherently predisposed in that sense.
What we are saying is that our population is younger, and that is why we see more heart attacks in a younger age group than
because we see far more younger people with heart attacks because we have a larger younger population. So that in itself should not make people anxious that people are having more heart attacks in young people. So that is number one. The second thing is, even when you look at heart attacks across the world, there are studies which have looked at it. If you look at it, the the way we explain heart attacks is by the presence of risk factors. So, for example, if somebody is diabetic, hypertension, they have a bad cholesterol, they're not physically active, they're eating unhealthy. So all these things contribute. We know that all these things contribute to the risk of heart attack. So if you look at it across countries, so there are some studies which have looked at the risk of heart attacks across countries, and then you try to explain this risk by the prevalence of how common the risk factors are. Then you can explain about 90% of heart attacks based on these known risk factors, which are not rocket science. So you have diabetes, hypertension, things like that. So this 90% of heart attacks are explained both in the Indian context and also in Western countries. So the message being that most heart attacks are explained by the existence of risk factors in this population. Now, having said this, I just want to clarify, there is one truth to it. This does not mean that we don't have a problem. We have a huge problem because although the number of heart attacks is similar given an age standardized population, our risk of dying of heart disease is quite high, is much higher than in the West. So that is because of several other factors. So again, there are studies multinational studies which have done where they've looked at what are the reasons. So we typically, the country income is linked to the risk of death. So somebody from a poor country, so low middle income countries tend to have a higher risk of dying of heart disease than high income countries, although the risk may be similar or maybe even greater in higher income countries. So that is basically related to the access, affordability of care, the health seeking behavior of the population, and so many other things. So it's not a risk per se, inherent risk of having heart disease, but the risk of dying is much higher in India. So we really have a problem, but the problem is we have to identify the problem as not an inherent predisposition, but the way we tackle heart disease is more important.
Right. Coming back to, when we talk about lifestyle, and do you think that of late the lifestyles of not just Indians, but everywhere around the world, we've had a shift in the lifestyle which makes us, by us, I mean the entire population of the world, more at risk of cardiovascular diseases? Is there a shift in how we are living our lives that increases the risk of us, getting heart diseases at a younger age?
Yeah. So here again, there is a bifurcation in terms of how we see us and the rest of the world. Again, there's a problem with us, but the rest of the world, if you see rich countries, the risk of dying, everything else has been slowly coming down over the years. Whereas our risk of dying is more or less plateaued. It's not changing too much. In fact, in some places, it may be actually going up. So that is a cause for concern. And most of this is attributable to our higher prevalence of, say, things like diabetes and poor control of blood sugar, poor control of blood pressure. So in fact, there are studies which have shown that people who have heart disease tend to use medications, commonly used medications, which are known to reduce the risk of dying of heart disease, like, say, cholesterol lowering drugs or other medicines, far less frequently than in rich countries. One example is the cholesterol lowering drug, which is used commonly in patients who have heart disease. It is shown to reduce mortality due to heart disease. It's used in about 5% of people in India, for example, when compared to nearly 70% of people in high-income countries, so Western Europe and things like that. So that makes for a big difference. So this is something which we need to address in our country.
So why do you think that is? Like, this is an anecdote I heard actually from recently from someone who got a cholesterol test done, since we're talking about that earlier I believe the LDL, that is the bad cholesterol levels, used to be that's what is considered optimal is around 100, I believe, and now labs are trying to say that and something lower than 100 is also risky, and a person should consult or start medications or start controlling their diet, or become more concerned at a threshold that is lower than what we used to consider optimal up till now. So is there any science behind it? Is there any science behind lowering the threshold of what is considered to be a risky level of bad cholesterol?
Oh, I think we should step back here a bit. So we've not reached that stage yet. These are things up for debate. I mean, we can debate it in, say, scientific societies. This is still very debatable. So the problem is that we are not even getting those, our patients are not even getting those medicines. So it's, like I said, 5% versus 65 or 70% when compared to, so we are not getting the medicines in the first place. So it's not about the targets yet. So people who have heart disease have to get all medicines. So that itself is a problem because of several reasons. Our patients are poor, they have a different health seeking behavior and things like that. So we need to address that more if we have to reduce heart disease, death due to heart disease, for example. So that's not, let's not go into the details of, what are the targets and things like that. That is a little more, see, as in everything, you have diminishing returns as you become increasingly stringent with anything. So the most important or the largest benefits are accrued when you start the medicines. So the initial step itself gives you most of the benefits. After that, increasing it a bit, reducing targets further, may or may not increase your, give you more benefits, but there is always a diminishing return in terms of benefits. Right. So it's important to get the first thing right.
Right. So, when you talk about the problems about why a lot of people do not really get the right kind of medicines, or a lot of them actually, consult doctors very later in life, and it's not until it's reached a level that is causing visible discomfort that a person gets themselves checked in a lot of households in India. I mean, even in middle class households. So what do you think, what is the point where one should worry and one should see a doctor? What are the signs that one should look out for when say they are past 35 and should start worrying about their heart health?
So this is down to very simple things. So basically, you just need to be active, physically active, remain physically active. You are very physically active in your generally in our college days, and then we stop becoming physically active. So that is number one. You have to be physically active, continue to be physically active, eat healthy, and get your blood pressure measured at least once a year. If it is high, especially when you have family history of blood pressure, somebody in the family. So it's likely that at some point in your life, you'll become hypertensive. So it's important to check your blood pressure at least once a year. And once you become 35 or so, then it's also good to look at your blood sugar, total cholesterol, things like that, just to get a sense of where you are. So your risk factors, so remember, so we've been exposed to a lot of social media hype about testing. Now, what we are talking about is not testing. So there are two different things. First is risk assessment. Let's call it risk assessment. So what we are doing is risk assessment. You're trying to look at blood pressure. You're trying to look at physical activity. You're trying to look at blood sugar, cholesterol. These are measures by which you do risk assessment. Whereas what people have been advocating, for example, do a CT scan in everybody at 40 years, which is screening for heart disease, which is a completely different issue. While one of them we are recommending very strongly, the other one is to be reserved for very highly selected patients. So it's people.
And why is that? Why is CT scans supposed to be reserved for selected patients?
So I will talk about it in the context in which it came up right now. So it came up in the context that somebody, while exercising, died suddenly, had a heart attack suddenly, right? So the implication, the understanding is that what is being conveyed in these social media postings, posts and other things is that if you do a CT scan, you will know whether you have heart disease or not, and then you will take appropriate measures so that you don't die of heart disease. Now, this has several several implications. For example, so first of all, let us understand that the risk of dying suddenly during exercise is minuscule. It's very, very small. It's actually, people have studied this. So it's actually 1 in 15 lakh bouts of exercise. So that's a very large number of bouts of exercise. So typically, if somebody is exercising for 60 years in their lifetime, they will only accumulate about 15,000 bouts of exercise. So the risk of dying like that is pretty small. And also remember that somebody who is regularly exercising has a far smaller risk of dying suddenly during exercise than the general population. So the risk of dying suddenly in the general population, in people who are just free living people, is higher than the risk of dying during exercise. So that also has to be remembered. So it's tragic when you find that somebody who's young, who's exercising, who's very fit, dies suddenly. But let's also remember that given in the context of that, if you look at people who are exercising regularly, the likelihood that they will die suddenly during exercise is very, very small. It's much smaller than the general population. So that is number one. So second thing is the implication of doing, the expectation when you do a CT scan is that, okay, you will find something and then you will be able to do something which will prevent that person from dying suddenly. Now that is not shown. So the studies do not suggest that if you do something like this, you will be able to prevent a heart attack later on in life when this person is exercising. So that is number one point. So this does not achieve the objective that you are doing, that you set out to achieve. The second thing is no test is perfect. Every test identifies people who have the disease, and it also identifies a lot of people who do not have the disease as being abnormal. So these are, let's call them false positives. Now, what happens to these people? Supposing you do a CT scan in a 40-year-old guy and it's not perfectly normal, but there is some minor abnormality that you get. So what happens to them? They are told that there is something abnormal. They stop exercising. They go on to get some other test, because once you see something abnormal, somebody is so anxious, you end up doing other tests. Now, this leads to a cascade of testing, which is increasingly invasive and increasingly meaningless. I mean, it will not be beneficial. Some of these people end up getting, stents and things like that, which were never required in the first place. So that is the second downside of all this. So there are several problems with taking this approach where you say that simplistically you do a CT scan and everything is okay, you go on. If something's abnormal, you don't do it. So it doesn't work like that. So there is a problem with this kind of thing.
But how does a lay person like me, and anyone else know the difference between, when something a doctor is saying is something that is required, or just like you said, like that it'll lead to a series of unnecessary tests?
So this is a very tough question. So we unfortunately don't have a regulated healthcare system. You see, you can't blame every doctor who's advising this also, because there is always going to be one patient who did not do well. So, and that patient is going to hold it against this person. So there is always this tendency to practice defensive sort of medicine. But it's always good to look at, get an unbiased opinion from. You can consider it my bias, but you can always talk to somebody in a government setup where it's not fee for service, where there is no incentive to do more procedures. So that's one way of it. Otherwise, I really can't suggest a better way. So it's actually fraught. This whole problem is a problem.
I think that's what gives this whole consulting a family doctor so much importance in a country like India, where it's someone you trust. Who can give you an opinion that is not biased.
Yeah, we should not paint everybody with the same brush also. So it's difficult for people who are practicing in private also, that they are subject to different kinds of pressures, which I acknowledge. One more way of looking at it is, there are these guidance documents for patients. for people. And these are routinely given out by authorities, health authorities in England, for example, which is not a fee-for-service system, which is a single-payer system, which is less biased than, say, the American system, for example. So you could consult. I mean, patients who are educated can consult these. Obviously, patients who are not educated, they have to rely on going to somebody they trust. So these are some things which you can look at. The classic example of this, which is perpetuated so often by the whole system as such, is this executive checkups, which are done every year, for example. They're required by the organization. They go on and get it done. So that involves a whole battery of tests, which includes both risk assessment, like we talked about, which are good, but there's also something for screening. So they end up doing things like exercise testing, which is a very imperfect test and which gives a lot of false positives. So it gives a lot of anxiety, unnecessary testing, and people go on to get unnecessary procedures done. So that's really something.
So there is a dire need to have better guidelines that everyone can follow, more communication around these kind of tests, what they mean, who should get them, and I think that is something that a lot of people don't have access to in our country.
But guidelines are already there. Guidelines, scientific bodies give out routine guidelines. So whatever this recommendation that everybody above the age of 40 should get a CT scan is not supported by any guideline or any science. So it is just a statement which probably should be ignored. I just made some notes which I hope I'm not missing something. Yeah. Go on.
All right. So one more thing, I have read a lot about the difference in what symptoms and markers are seen in men when it comes to cardiovascular diseases and what can be seen in women. Do you think there is a gap in how we understand women's bodies in terms of heart diseases and men's bodies? And is there something that women should be aware of, that they should take care of and not miss out on when they are, when we are talking about women's health and women's heart health?
So the good news for women is that they are protected from heart disease when compared to men for a long time, till they are menstruating. So they are very much protected. So the risk of, say, heart attacks is much lower than in men. But this risk starts diminishing as the woman reaches menopause. That's a good thing. But then all the risk factors that we talked about apply equally to women. So in order to say enjoy the protection of the hormones that give them protection, women also have to look at all their risk factors and take care of those risk factors. Otherwise, they then become their risk starts coming closer to men as well. So all the rules apply to both sexes in that sense. But women are generally a little more protected till very late in their lives.
Right. So another aspect of heart health and coming to private practitioners, this is something that I actually happened to visit a heart wellness clinic some years back, where I saw something called vibration therapy, which is supposed to be better for your nervous system, circulatory system, and what they did was they had packages for age groups as young as 25 to 35. So from what I understood was they basically had a program for everyone, irrespective of whether or not you had been diagnosed with a heart disease. And they just said that, okay, there was no harm doing this, only good can come out of it. So have you come across such practices, and what is your opinion of this fad of vibration therapies?
I've never heard of this. I'm sorry. Okay. I don't know of anything like this for everybody. So I don't think. There are many treatments which are given like this. I mean, known treatments also, which probably are not given. Are given in people in whom it's not indicated, for example. But this one I've never heard of.
Right. So, in general, does a person who's 25 to between 25 to 35 need to worry about, his heart health? In general, like a person who's otherwise visibly healthy?
No, I don't think you should worry about it. Just take care of all the things that we mentioned earlier. Be physically active. So the risk of heart attack starts rising 35 years or later. So it starts rising that way, unless there are some other diseases which you have a family history of high cholesterol or things like that. That may increase your risk. But in that case, you will already know it. But otherwise, a normal person, a normal healthy person, need not worry. I mean, you never need to worry. I mean, you just need to take care of these small things and you should be fine. Uh, the exercise part is something which I thought you were going to talk about, because that is something which is very critical, because Indians are generally much more sedentary than the rest of the world. I mean, you look at an Australian or an Australians, South Africans, they're far more physically active than the average Indian. So I think this my complaint against this viral WhatsApp post is only this. I mean, you start putting up barriers to people uh, who want to exercise. You want to say that, okay, you get this test, then you exercise. So these are barriers. We don't want them. People should exercise. Exercise is pretty safe, and I mean,
Basically, know and respond to your body, right? I mean, exercise is only it obviously has a lot of benefits, and that is something that has constantly been an advice that we've heard from doctors, that you do need to, and I'm sure like everyone knows when they're pushing their body beyond their limit, that is when you should stop, right?
Yeah. I mean, so specifically, people have said that running on a treadmill is bad for you, or I mean, this is what came up in recent times. I mean, if you want to run on a treadmill, you have to get tested before. So all this is not true. So for a typical healthy person who does not have the risk factors that we talked about earlier, who's been relatively active, who's been walking. So if he wants to start an exercise program, he should do it, and you should take a sensible approach to it. You start slowly. You don't start off by running a marathon, right? Mm-hmm. So you start slowly. You build up your physical capacity, and then you reach to whatever you want to do. And a heart. So it's often important to remember what is your level of exercise. So for somebody like who's 60 years old, who is a little obese, brisk walking may be very, significant exercise. But for somebody who's 40, who's physically active, running on the treadmill is the same equivalent, right? So we cannot, exercise has to be tailored to each person. So we cannot say that running on the treadmill is bad for you. I mean, obviously a 65-year-old man who's been sedentary, who wants to start running on a treadmill, that's not correct. I mean, you have to scale up slowly. So these are things that we should keep in mind. I mean, we should not have a blanket statement that people should not run on a treadmill. That's not true. Right. And you don't need testing, definitely, for somebody who is normal, who doesn't have symptoms, who doesn't have risk factors. You just don't need any testing.
Right. All right, sir. So the key points that we got from this interview was one, follow a healthy diet and exercise for sure. Do not put a blanket ban on exercises based on, a generalized statement, but do know what is right for your body and do not push it beyond that limit. But a regular exercise is definitely going to go a long way in.
Yeah, that may be it may help people. So everybody has a tracker nowadays. I mean, you have a fitness band or something.
Or you have your phones.
Yeah. So one way of looking at it is, so for every person, supposing you're 40 years of age, so you can calculate the, say, maximal heart rate for you. So that would be simply by subtracting from 220. So 220 minus 40 is 180. So 180 is the maximum heart rate that this person, a 40-year-old person, can achieve. That's the maximum heart rate. So when you're starting exercising, you can go up to 40% of that target heart rate, and then slowly scale up to 70% or 85%. So this range would be mild to moderate exercise. Beyond 85% of that target heart rate may be considered vigorous exercise.
That's actually quite interesting.
People can just look at it and know for themselves what level of exercise they are doing, what is comfortable for them, and they can go on. Obviously, if you develop symptoms during exercise, or if you start having problems, then you obviously have to consult. So it's just a common sense approach. My only repeated statement would be, if you've been normal, if you've been the other point that I'm sorry, I forgot about this. The other point that was made was that if you've been exercising, if you've been running 10 miles a day, it doesn't mean that you'll not have a heart attack. No, that statement is absolutely wrong. If you've been running for, let's say, you're running 10 miles a day, you're an athlete. You don't have to worry. I mean, you have the lowest risk of dying during exercise or otherwise. So no problem. If you don't have symptoms, you're doing this 10 miles a day run, please continue to do it. So absolutely fine.
So right, so don't worry, live your life, and
take care of the small things. Yeah, definitely not. Don't get tested unless it's required. The important rule to remember is, if you find something on a test, what do? If you do that, does it really help you in the long run? If the answers to these two questions are you don't know, or we don't know, or whether it doesn't, then don't do it. That would be the recommendation.
Right. So Dr. Karthik, so to summarize, what are the main points that a person should keep in mind in terms of, how they will exercise, and what are the main points that they should keep in mind?
Okay, so the three takeaways I just want to emphasize here for people is, first of all, don't be anxious that you're Indian. Being Indian does not automatically predispose you to having heart disease. It is just that you need to take care of risk factors. You're just, if you don't have risk factors, if you take care of risk factors, you're just as much at risk of heart disease as anybody else in the world. So don't worry about being Indian. Don't be anxious about being Indian. The second point is, if you want to exercise, it's extremely safe to exercise. You don't need testing. If you are completely asymptomatic, you don't have risk factors, you may go ahead. Just be sensible about it. Just start slow, increase as your body allows. And like we said earlier, you can look at your heart rate and don't overdo things. The third thing, and also exercise is different for different people. So for some people, it may just be brisk walking, but for somebody who is more fit, it may be running. So it may be just as good. So there is no one prescription for everybody. It all depends on how you are. So it doesn't mean that if you're running on a treadmill, it's bad for you. If you're fit enough, if you're doing it well, it's fine. And you don't need testing before embarking on something like that. The only time when you need testing is if you have some risk factors, or if you have symptoms when you're exercising. So that is something when you need to, you may not need testing, you just need to take advice before you start. You may not need testing even then. We're not talking about people who are athletes, for example, people entering competitive athletics. There, the question is completely different, and that's a discussion for another day. That's not for common people, so we'll not talk about that. The third thing is about the intensity of exercise. So, like I said earlier, there is no one prescription for everybody. You can start slowly, and you can use heart rate, like I said, how to calculate maximum heart rate. So you can start off at 40% of that and go up to 75, 80, 85% of that, and you'll be perfectly all right if you don't develop symptoms. And gradually scale up. Don't go all at once. And always remember to warm up a little bit, 5-10 minutes before, and cool down after that. So you'll be fine most of the time. So that's I think if you remember that much, I think it's fine.
All right. So those were the 3 points. So thank you, Dr. Karthik. Thank you once again for joining us. Thank you, our viewers, for listening in. And don't forget to hit the subscribe button if you like our videos. This is Mohana Basu, special correspondent at ThePrint. Thank you.